Namaste Vidya, Amisha Kushal. A very good morning to all. Myself, JV'n, Assistant Professor, Department of Pathology Medicine at Faculty of Homeopathic Science, JAYOTI VIDYAPEETH. Today, we are going to start with a new topic, that is inflammatory bowel disease. In inflammatory bowel disease, we have two diseases, that is ulcerative colitis and Crohn's disease. Today, we are going to study about ulcerative colitis. So let's start with inflammatory bowel disease. Inflammatory bowel disease is an immune-mediated chronic inflammatory disorder. So this is basically an immune-mediated disorder with chronic inflammation of immune etiology, whose etiologies are known, involving the gastrointestinal tract. So the gastrointestinal tract is involved. I will again repeat the definition. Inflammatory bowel disease is an immune-mediated chronic inflammatory disorder of immune etiology involving the gastrointestinal tract. There are two major types of inflammatory bowel disease. One is ulcerative colitis and second one is Crohn's disease. As you can see in the picture, the Crohn's disease is characterized by skip lesions and ulcerative colitis continuous lesions. We will be taking the different characteristic features. We will be studying about different characteristic features of both the disease condition one by one. In today's lecture, we will be studying about ulcerative colitis. So, ulcerative colitis is a mucosal disease that usually involves the rectum and extends proximally to involve all the other part of the colon. So, as you can see in this picture, it starts from the rectum and then extends proximally to involve the colon. The proximal spread occurs in continuity without areas of uninvolved mucosa. So this could be understood here that there is a continuity of the lesion, whereas in Crohn's disease there is discontinuous patches. Here is the disease condition: normal, disease, normal, disease. This is known as skip lesions. Whereas in ulcerative colitis, we don't see any kind of skip lesions. The incidence is 10 to 20 per 1 lakh population. The age of onset: it is second to fourth decades of the age group that is most commonly affected, and 7 to 9 decades. So it has a bimodal distribution, age distribution. First one is second to fourth decade, and the second one is 7 to 9 decade. The individuals are most common. Female to male ratio is 0.51 to 1.58. Antibiotic use in the first year of life increases 2.9 times the risk of development of childhood inflammatory bowel disease. So if the child is using a lot of antibiotics during childhood, because of any of the cause, then it can lead to increased development of ulcerative or inflammatory bowel disease. The other causes include smoking, that is an important risk factor, infectious gastroenteritis with pathogens like Salmonella, Shigella, etc., increased risk of inflammatory bowel disease, risk by 2 to 3 fold times. The diet is high in animal proteins, sugar, sweets, oils, and dietary fat have increased risk of inflammatory bowel disease. So, if you are taking a diet which is rich in animal protein, sugar, sweets, oils, and dietary fat, that can increase the risk of developing bowel disease. Inflammatory bowel disease is basically a familial disease, runs among the families. Now, what is the pathophysiology? Inflammatory bowel disease develops because of the abnormal host response to an environmental trigger in genetically susceptible individuals. So, this is basically a genetic disease that runs in family. It develops because of abnormal host response to an environmental trigger. So, there is an abnormal response to environmental trigger. It causes inflammation of the intestines and releases inflammatory mediators. So it causes inflammation of the intestine and releases inflammatory mediators such as TNF, interleukins 12, interleukins 23, which can cause the tissue damage. The intestinal wall is infiltrated with acute and chronic inflammatory cells. So the inflammatory wall is infiltrated with acute and chronic inflammatory cells. The difference is in the distribution of the disease and in histological factors. So the difference that arises from the distribution of the disease and the histological factors. Now, what is the macroscopic pathology? What can we see on the macroscopic level? It involves the rectum and extends proximally to involve the other part of the colon that I have explained already. That it starts from the rectum and and it spreads proximally to involve the other part. The proximal spread occurs in continuity without any areas of uninvolved mucosa. That is, there are no skip lesions that I have already discussed with you in the picture. So there is continuity of the lesions. The inflammation extends 2 to 3 centimeter into the terminal area, that is known as backwash uveitis. With mild inflammation, the mucosa is erythematous. So there is inflammation with erythematous mucosa, and there has a fine granular surface that resembles the sandpaper. So there is sandpaper-like appearance. In the severe disease, the mucosa is hemorrhagic, edematous, and ulcerated. So the mucosa can become hemorrhagic, edematous, and ulcerated in severe kind of disease. Hemorrhagic, edematous, swollen, and ulcerated. There is mild inflammation. The mucosa is erythematous and has fine granular surface that resembles sandpaper. This I have already told you. The inflammatory polyps, pseudopolyps are present as a result of epithelial regeneration. So as a result of epithelial regeneration, pseudopolyp develops. Pulmonary disease can develop a toxic colitis or a megacolon, where the bowel wall thins and the mucosa is severely ulcerated. That can lead to perforation. I will again repeat this thing. The pulmonary disease means the severe disease can develop a toxic colitis or megacolon, where the bowel walls thins and the mucosa is severely ulcerated. This may lead to perforation. The microscopic pathology. It is limited to the mucosa and superficial submucosa. So mucosa and submucosa is involved, with the deeper layers unaffected except for the fulminant case where ulcerations can be found. The mucosal vascular congestion with edema and focal hemorrhage can be there. The inflammatory cell infiltrate of neutrophils, lymphocytes, plasma cells, and macrophages are present. The neutrophils invade the epithelium, usually in the crypts, giving rise to cryptitis and ultimately to crypt abscesses. There are features of villus atrophy and crypt regeneration. So the villi atrophies and there is crypt regeneration that is found. Now, what are the clinical features of ulcerative colitis? Whenever a patient of ulcerative colitis is coming to us, he presents with the following features. They have been present, the features have been present for weeks to months. The major symptoms include diarrhea, there can be rectal bleeding, tenesmus, the passage of mucus, and crampy abdominal pain. I will again repeat these symptoms. There can be diarrhea, dust लग सकते हैं उसको, rectal bleeding हो सकती है. There can be tenesmus, मरोड़ चल सकती है उसको, and the passage of mucus. And there can be crampy abdominal pain. Occasionally, the symptoms are so mild that the patient does not seek medical attention. So initially, the symptoms are very mild, and the patient does not bother to go to the physician. There is tenesmus and urgency, with a feeling of incomplete evacuation. There is a feeling of incomplete evacuation, tenesmus and urgency first, but rarely abdominal pain. In severe cases, the patient passes a liquid stool containing blood, pus, and fecal matter. So the patient passes bloody stool, pus containing pus, and fecal matter. The diarrhea is nocturnal and postprandial. Means after eating food, there is diarrhea and acne. The other symptoms include anorexia, nausea, vomiting, fever, and weight loss. So the symptoms include anorexia, nausea, vomiting, fever, and weight loss. These are the common symptoms. Now, what are the different lab investigations that can be done? There will be a rise in C-reactive protein. There will be rise in the platelet count, erythrocyte sedimentation rate, decrease in hemoglobin, and leukocytosis may be present. Now, to repeat the lab investigations, C-reactive protein, we have to find out platelet count, the erythrocyte sedimentation rate, the decrease in hemoglobin, leukocytosis. These features can be present. The diagnosis is based, now the diagnosis will be based on the patient history, the symptoms that he is bringing to us, the clinical symptoms, negative stool examination for bacteria, and histology of rectal or colonic biopsy specimens. Sigmoidoscopy is used to assess the disease activity before the treatment. So before the treatment starts, we go for sigmoidoscopy. The colonoscopy to assess the disease extent and activity. Colonoscopy is done to see for the extent of disease spread and its activity. The disease can be divided into three categories: mild, moderate, and severe. So in the mild disease, it is characterized by erythema, decreased vascular pattern, and mild friability. So there is erythema, redness, decreased vascular patterns, and mild friability. In the moderate disease, it is characterized by marked erythema, absence of vascular pattern, friability, and erosions. In the severe disease, it is characterized by spontaneous bleeding and ulceration. So in the severe case, there are ulcerations. Radiologically, single contrast variant anemia is fine and it is granular because granular pattern is seen. So radiologically, in the bleeding anemia, we found mucosal granularity. With the increased severity, the mucosa becomes thickened. With this increasing severity, the mucosa becomes thickened and superficial ulcers are seen. There are collar button ulcers which indicate that the ulceration has penetrated the mucosa. There is loss of frustrations that can occur with long-standing disease. So, loss of frustrations are there, which occurs with long-standing disease. The formation of pseudopolyps is seen. Right? There are formation of pseudopolyps. Computed tomography or the magnetic resonance imaging is not helpful. So, CT scan is not helpful in such cases. What are the different complications? 15% of the patients with ulcerative colitis present initially with catastrophic illness. So there is catastrophic illness in 15% of the patients. Massive hemorrhage occurs in severe attacks of the disease in 1% of cases. So 1% present with massive hemorrhage. Toxic metacolon, a very important condition, a transverse or right colon with a diameter of greater than 6 cm with loss of obstructions in patients with severe attack of ulcerative colitis. So there is a transverse or right colon with diameter of greater than 6 cm with loss of obstructions in patients with severe attack of ulcerative colitis. It occurs in about 5% of the attacks and can be triggered by electrolyte abnormalities and narcotics. The perforation is most dangerous and the local complications, and stricture can occur in around 5 to 10% of the patients. So this was all about ulcerative colitis. In the next lecture, we will be discussing about the Crohn's disease and treatment of the inflammatory bowel disease in common. So this session was powered by digital version 2.0, JAYOTI VIDYAPEETH. I hope you are satisfied with my digital session. If you have any queries, mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will meet in the next lecture with Crohn's disease. Thank you.